My name's Matt. On behalf of the entire Maxius team, thank you for spending some time with us today. If you're wondering why Maxius is sponsoring a BioXclude lecture, it's because BioXclude, and myself included, we were acquired by Maxius last September. So we're now underneath the full Maxius umbrella. So with that, I'm excited to turn this over to Dr. Megan Ratliff. It's all yours.
Well, thanks for that introduction, Matt. I'm very excited to be here. I'm Megan Ratliff. I am a board-certified periodontist. I practice in Glenview, Illinois, just on the north side of Chicago. And I have been part of this greater family, Maxius, included in BioXclude, for several years. And so I'm excited to be up here today to tell you about this membrane that smiles back to us. This is a membrane that really makes you smile because of everything that it can do. And then when we put it in the patient, it just smiles right back. With us being in Seattle, I thought that we'd start this out with a little bit of fun. And so we have this guy.
Starbucks. I don't know if that's true, but a lot of people do say that. They say they burn it. And you would think that if enough people were talking about it, that maybe that would make it back around to Starbucks, to where Starbucks headquarters would be like, hey, maybe we turn it down a little bit, Like we don't have to burn it. Like it could still be hot, without burning it. But I think the CEO of Starbucks is like, nah, burn it. They'll drink it, burn it. They got a camera in every store watching dudes like me go, ugh, Starbucks. They're like, look at him, he doesn't even like it. He'll be back tomorrow, though.
Yeah, so I don't know how many of you think that Starbucks coffee tastes like it's burnt, but maybe he's onto something. All right, so this guy thought that was funny, and this guy likes to laugh and smile at all the stuff that BioXclude does. So this is the membrane that you would see in your office, smiling right back at you. But this is how that little guy came to be. So this is a placenta, and probably none of you are like, yay, I want to go to a lecture today and see a placenta that's just come out and not even see the baby that came out with it. But this is the membrane that will become that smiley membrane in your office. Okay, so where do we get that placenta? These placenta come from planned cesareans and they're live births. And so they show up into these donor facilities, and it goes through a hand processing process. So the epithelium is removed, and in the process of the epithelium being removed by hand, the spongy layer gets destroyed. So then you have two pieces. You have the amnion and you have the chorion, and it's made up of each of these layers. The tropoblastic cells in that bottom layer is where all of your growth factors, majority, 80% of the growth factors are coming from. And so we see each of those layers listed here. So here are the properties and mechanisms of action of the membrane. So suppression of inflammation, antibacterial factors, and induction of death of inflammatory cells. These are all things that are inherent to this type of tissue, because if you think about it, this tissue is what is protecting the baby, helping the baby to grow. So the epithelial tissue, it stimulates epithelial cells from that basement membrane. It has the keratinocyte growth factors. The mesenchymal tissue has the tumor growth factor beta suppression, reduction of scarring, the regeneration and neural factor growth, and then the biomechanical properties is the avascular, that it does not have actual cells. So that means that you're not going to have an immune response. Even though this comes from a human tissue, we don't have an immune response in our patients. And it's durable, it's elastic and translucent. Once it's moist in the patient's mouth, it becomes very kind of stretchy. and it serves as a physical barrier. So if we look at when the cells are released, when we're using this membrane, which is different than PDGF or MDGAIN, is that over the 96 hours, we actually have an increase in release of growth factors. Okay, so here are the competitors that are on the market. So we probably know that Snoasis, formerly Snoasis, that BioXclude was the first company that came out in the dental market. If we look actually at these amnion-chorion membranes, they have been used for years and years and years in medical, starting back as early as 1910, when they first used an amniotic membrane in a human patient. So medical was on board with the potential of these types of membranes with healing and growth factors. It was within the dental sphere that BioXclude was the first. And then we started to get these other membranes that came out, and they're processed differently. The two in the corners, the Biotivity and the Memlock Amnion, both of those are processed keeping the whole membrane, similarly to BioXclude. However, the processing that they do, they don't remove the epithelial off the top. So their membrane just doesn't have quite the same potential that we have with the Snoasis membrane, or with the BioXclude membrane. Now, the AlloGuide and the amniocyte, both of these, as we'll see in the next slide, are lyophilized. And so in that freeze-drying process, we lose some of the potential of the membrane. Now, to keep your mind clear on things, when AmnioExcite says we are a 3-layer amnion-chorion membrane, that's not really totally true, because the tropoblastic layer that they're considering a layer, making it 3 layers, is actually part of the chorion. So it's all combined into one. They're just separating it out to make it seem like you're getting more bang for your buck. So this is a slide that just kind of shows what happens in the different types of processing and what kind of membrane you're dealing with. If we look, actually, this was a poster presentation that was here at AO a few years back. And if we look at this, this is showing those 3 membranes. So the Salvin membrane, the 2 lyophilized membranes, and the BioXclude membrane, we can see that there's actually a better antibacterial property to the BioXclude membrane. And then this is actually a slide that came from this article that was published in the Oral Microbes International Dentistry, which shows how antibacterial this membrane actually is, because it's compared to another paper disc with tetracycline in these different agars. And you can see that at different dilutions, the BioXclude membrane does not grow any bacteria. So statistically speaking, only 1 in 7 dwarfs is happy. Okay, so now we'll move into some clinical cases. This is Angela. And Angela, I like to think about her like a gumball machine or like a gumball. And you'll see why. So I've treated Angela for quite some time, replaced teeth in the upper anterior, did some different things, and then she was losing this bridge that she had on the upper left. But she had a pretty... she had a pneumatized sinus, and so she was going to be a sinus augmentation. Now, things that I like about Angela is that she has a nice, thick gingiva. And so that's just something to note, that in general, cases with these nice, thick biotypes are really your favorite patients. So here's the case. When I do my sinus augmentations, I typically open the window, sometimes depending on how thick the wall is. I open it with a carbide burr, and then I switch to my piezo once I get a little closer towards the membrane. And then as I lift the membrane, I use the piezo surgical, and then I use some hand instruments as well. I lifted the membrane. I place a cortical cancellous mix of both allograft, and then I also do a xenograft, and then my BioXclude membrane over the access window. So here are the sutures, and there's the gum ball. So a nice big round elevated sinus there. So she went from about 2.5 millimeters of vertical height to 15. And she healed for 6 months, and then 2 implants were placed, 1 immediate into number 13 and then number 14. And then this is Angela once she's been restored, and 1/4 into the gumball machine, and she got 2 implants.
Hey everybody, who's ready to laugh? And what's the deal with lampshades? I mean, if it's a lamp, why do you want shade? And what's with people getting sick?
Yeah.
I mean, what's the deal with cancer?
I have cancer.
Tough crowd.
So, similar to what Jerry had here, sometimes things bomb and sometimes things don't go exactly the way that we hope or expect them to go. So in Angela's case, she had a nice thick sinus membrane, just like she has a nice thick tissue, easy to work with, but sometimes that's not what happens. And sometimes you end up with the hole in the sinus. So this is an article that was published by Dr. Hartzkla, and it's about maxillary sinus membrane perforations. It's estimated that between 11 to 56% of Schneiderian membranes are perforated. And so in this, he did cases from 2009 to 14, and he did a total of 77 cases and did sinus elevations in 104, 9 of which had perforations. So here you see what he was doing was he had the perforation, then he took a nice big membrane, BioXclude membrane, and placed it over the perforation. So here's the video. You can get it to stick right over top of the perforation. And so he placed the membrane, then he placed the graft, and then another membrane over top. And so of those 23 implants that were placed into previously perforated sinuses, he only had 1 implant failure. And this is a case that shows at placement on the left, and then on the right, it shows the 6-year follow-up.
I realized that figure skating, as brutal as hockey is, figure skating is much more brutal, barbaric even. They make the woman finish skating after she's fallen. Lowest point in your life? Keep dancing, sweetie. Yeah, try another Lutz. They should race the Zamboni out there, scoop her up and whisk her off into a private room where they give her a carton of Marlboros and a pillow to scream into. She's not gonna win. It's over. You never see a woman on the gold medal stand with slush running down her thigh.
Okay, so meet JoJo. Funny thing about this, I don't know how many of you have seen Blades of Glory, but it's a pretty great movie. But the Crest White strips actually did sponsor them in Blades of Glory, which I thought was very apropos for JoJo, who ended up like this after attempting his Blades of Glory on the ribbon around Millennium Park in Chicago on Christmas Day ice skating. So he took a nice face plant, and he had problems with the anterior teeth at the time. They restored them with crowns and gave it a little time, and now he's losing all the bone and a nice big infection in the area. So that's the defect that I was dealing with in his case. And so what I did there, removing all of that, and And number 10 is somewhat compromised because of the bone loss on number 9. So this area was degranulated, and that's really the most important thing with any of these extraction cases, is that we remove every last piece of granulation tissue and make sure that we're down to good solid bone. So removed all the granulation tissue, placed the graft, and placed the BioXclude membrane on the buccal, and then tucked it and sutured. You can see that little corner that I went back after taking my photograph and tucked that back in. The thing about this membrane is when you're placing it, it's dry, right? You're going into the mouth, it's dry. You're using a dry cotton plier or something to hold it, to put it to where you want to put it. Then you're taking wet instruments and tucking with the wet instruments. And sometimes if it's thicker, because there can be a little bit of a difference between each of the membranes that you're getting, because each placental tissue is going to be a little bit different. Some of them hydrate a little faster than others. Some are a little thicker than others. And so you'll use maybe a little bit more sterile saline if you're not feeling like it's hydrating in the patient. If the patient's super bloody, it's going to hydrate very quickly with the blood. So this is a post-op showing how much bone was placed in JoJo, and then this is his healing. This is at 3 months, and this is at 5 months. For grafts like this, I'm waiting a good solid 6 to 9 months, depending on what I'm seeing in their mouth, to make sure that it gives ample time for the bone to rebuild to be nice and solid. So he's talking about thinking about being like an animal. Now this is Joan. Joan is not the gopher. But as you'll soon see, it will look like Joan had a gopher. So she has a huge area of bone loss. And this case, similar to the last one, I opened up, cleaned out, removed all the granulation tissue, and did both a graft into that area and then a little bit to the buccal. So here's the graft, and I'm using a cancellous particulate, and this one was hydrated in tetracycline. And a BioXclude membrane. Here's the sutures. Here's the initial post-op x-ray. Here's her x-ray at 3 months. And I did a re-entry on her following 9 months of healing. So she had a really nice growth of bone in this area, both on the buccal and into the defect site. So the implant was placed. I waited 4 months and then did a temporary. This was one of the first temporaries that I did and placed. And so what we have here, now the thing about Joan was, so I saw her over the course of a year, placing the implant, placing the temporary, guiding the soft tissue. We got the papilla back, which was nice, a little bit of recession on tooth number 9. But then she moved away and had the tooth restored in Indiana. And so this x-ray came from the restorative doctor of the final restoration, but this photograph is the temporary showing where her papilla was before she left me. So I got that going for me. So this is Scott, and Scott is the strong guy. This is a case that Dr. Horowitz did, and this is a case that he had this fractured tooth, lost the crown lengthening's not possible. And this is the CT showing that there's the bone loss into the area where the tooth was, but there's also bone loss on the neighboring implant. So the tooth was extracted atraumatically, the area was degranulated, and then he did a mix of both Gen 21 with his bone graft, was the cancellous particulate, and then placed the membrane. And he obviously went back to tuck his membrane, and he didn't just leave the patient like this. And so the reason that I asked him for a case was because he loves to do histology on all of his cases. And so this was the trephine core that came from this area after 4.5 months of healing. And as you can see at the apical extent, you have good vital bone, and then as you move up, you still have vital bone, but he was estimating about 65 to 75% vital bone at the apex that's already turned over in that 4.5 months time. And then as you move up farther, more coronal, he estimated around 35 to 40% of vital bone. And I think the thing that we need to think about is we have these patients that are like, oh, I want an immediate implant. I want this tooth faster. I did a full mouth extraction on a guy, massive infections, and I decided to graft him prior to implant placement. It's been 2 months, and he's like, can we put my implants in? Can we put my implants in? I hate this denture. Can we put my implants in? And I think the important thing is that we really think about normal bone healing, how the bone heals, how we can use things to help the healing, but we still have to allow the body time to heal. And when we're taking films and doing things and saying, okay, we're at 2 months, we're at 4 months, and we're putting an implant in, sometimes that's not what that patient needs, and we need to pump the brakes and say a little more time. But anyway, so his implant was placed, and we see on the left side the time of placement on that film, and then on the right side, or the placement of the restoration, and then on the right side we see 5-year follow-up. So good bone healing there. Painless dentist liar. How many of our patients want to write that on a wall? Well, we try. So this is Mary, and Mary's my cookie monster. I like to think of her as a cookie monster because Mary has had teeth extracted on the left side and then teeth extracted on the right side, and it's because she likes to eat cookies and she likes to eat other fun things that have broken down her teeth over time. So here we have the molar, and she had a bridge several years ago, so here was the extraction, an atraumatic extraction with her edentulous space that we're going to place an implant in. And so the implant was placed along with that extraction. A bone graft was placed with a BioXclude membrane. And here is her post-op sutures and the post-op x-ray of the implant. And then I put the temporary back on, which she immediately lost after walking out of the office. And then this is at her post-op, and that is 4 weeks later. So we have good soft tissue healing in the area where the membrane was, and the bone is healing nicely. And who doesn't like Cookie Monster? So here's Sergio, and Sergio is one of those here and now kind of patients. He is a busy professional. He doesn't want to go without a tooth. He wants things right now, right now. So this is his pre-op. He has the failing tooth number 13 next to an adjacent implant, and the implant was placed. The gap was grafted, again with cancellous particulate, and then that cute little membrane that was smiling back at me saying, yeah, I'll help heal this area. And so this was how he left my office, and this was his post-op x-ray, and then he went to see the dentist, and this is his crown. So what Sergio will be back to see me for is a soft tissue graft in this area to see if we can rebuild that papilla. So this is Vitali and that guy. So Vitali was coming in for an implant in the site of number 30. And so I flapped him open. I started an osteotomy on him. He was originally going to be an implant with a buccal graft. because it looked like he was going to have well-contained walls. Well, it was a little thinner than what it looked like on the CT, but when I got to the base of this osteotomy, I could feel something there. Now, I did not do his extraction, so I don't know what that tooth looked like when it was extracted. But I took another look at the CT, and I could see something in the bone. Well, it was still some granulation tissue left from years ago when that tooth came out. So I ended up, as I was curetting down in there, lost that little bit of the buccal plate that I had, got that granulation tissue out. I placed a tenting screw. I placed the graft, and I placed a BioXclude membrane. Now, I go back and forth. Sometimes I'll use a BioXclude membrane over top of the bone because I want the growth factors that are going to leach into the bone and help it to heal. So obviously the bone grafts are going to get blood supply coming from the lingual, coming from the apex, coming from the walls of bone that we have remaining. But sometimes I like to say, okay, let's get a growth factor that's coming from another area that he doesn't have support. And then I place a collagen membrane. Other times I may place my collagen membrane and then place my BioXclude membrane over top, because then I'm getting an antibacterial component where I'm suturing, and it also helps to stimulate the epithelial growth that we may get better closure. So this was Vitali at 1 week, and then this is Vitali at 2 weeks. And this is his post-op x-ray. So this is Russell. Now, we all probably have some patients. I'm a periodontist, as I said, and so I don't place implants in every single patient that walks in my door, and a lot of that's dictated by the patient. And so for these next couple cases, you're going to see when I have been using this membrane for natural teeth. So Russell was one of those, like, oh, can we do a last Hail Mary or a life ring? So this is his x-ray, right? It's an endotreated tooth. He has a vertical defect on number 7. And you can see that it's like a 10 millimeter defect into that area. And I told him, Russell, this tooth is most likely fractured. This is a pretty classic fracture problem. And he goes, well, I don't have pain. The only reason I'm here is because my dentist found the pocket. Can we just do something to try to keep this tooth in my mouth? I've invested money in the root canal. I understand that I might leave it, but I want to keep it. So I cleaned that out the best that I could. I placed another cancellous graft and then placed a membrane that was smiling right back at me. And I sutured him up. And so this is his post-op sutures, and then his post-op at 2 weeks. And then this is Russell at 4 months. So the papilla were coming back, which is good. And then I'll just keep monitoring him. And at some point, he may end up being an extraction and an implant. But for now, he's happy that he still has his tooth. So this is Bad Luck Edward. Does anybody remember this Bad Luck Brian that used to pop up all over the place? No? Okay. So Bad Luck Edward comes into my office for a consult, and he has this decay on the distal of tooth number 2, and he's like, okay, I'll come back for my extraction. And this patient's older. He's in his 80s, and he's obviously not been a stranger to the dental chair with a lot of restorative work, root canals, the whole kit and caboodle. And so he presents to my office 2 weeks later for the extraction of tooth number 15. And what does he have? He has an abscess, not on 15, on 2. He has an abscess on tooth number 3 now. Bad Luck Edward was eating something and fractured the mesial root of tooth number 3. So good luck, Edward, ended up with Dr. Ratliff, who said, well, why don't we do a root amputation because you're in your 80s, and do we really want to take out 2 molars on a patient in their 80s? So I took off that mesial root, cleaned out the area. I placed a bone graft and a membrane, and I sutured him up, and this was his post-op x-ray. And this is 5 years. So bad luck, Edward. Looks like he's starting maybe to get a little bit of decay on tooth number 3 now, but tooth number 3 has given him 5 more years of life. Bad luck, Brian. All right, and that's what I have for you. But I hope that what you learned through this is that there is some great potential to BioXclude as a membrane with the growth factors that are contained within it. And it really is, after a big, long case where you're sitting there scraping granulation tissue out of someone for, the better part of a half an hour, 40 minutes. And I'm sure most of you can attest to the fact that the easier the tooth is to come out, the more time you're going to be in there scraping and scraping and scraping, that at the end of that, when you can put a little guy who smiles back at you, that you did a good job for that patient. But I would like to thank my brother who helped me with making some of these things a little more exciting. And of course, to both the doctors featured, BioXclude, Maxius, Solvita. All photographs were taken on location at Pure Perio in Glenview, Illinois. And where I'm from, we fly the W. Okay, thank you very much.